Okay. Now I'd like to introduce next speakers, Wonjun Song. He is a professor at the Gyeongbuk National University Hospital Chilgo, and he is the director of a high-risk pregnancy unit in Gyeongbuk National University Hospital and the vice chairman of a scientific committee of KSUOG. Actually, he is really excellent speakers and very famous sonologist in Korea, especially fetal echocardiography. So today he will show the case of the first trimester fetal echocardiography.
Hello everyone. First of all, it's a great honor for me to join this webinar. I think I am a novice in this field because I've used only transabdominal ultrasound for screening until recently. Actually, I don't use linear or high-frequency probe. I'm using standard probe just like most of you. So my video clips may not be as good as you expect, but if you think the other way around, my cases can be helpful at the level of screening using transabdominal approach. Let me share you my short experiences with small cases. Can you figure out the gestational age of this fetus? This is a transvaginal ultrasound of 13 weeks. The fetus is much bigger than you usually think. What about the fetal heart? This is a typical four-chamber view. The lower the frequency of color Doppler, the more abundant flow you can see. Normal cerebral view, and finally you can appreciate the lower and upper pulmonary veins connected to left atrium. This is the heart of this fetus. It's very similar to what you can see in mid-trimester heart. First, what's the checklist of first trimester fetal echocardiography? Left side clip demonstrates normal four-chamber view and cerebral view of 13 weeks. As Professor Radhakrishnan already mentioned, updated first trimester guideline from ISOC emphasizes the importance of four-chamber view, cerebral view, and left ventricular outtract view on grayscale or color Doppler. Before obtaining these anatomical planes, cardiac rhythm, situs, size, and axis should be checked. But in terms of screening, according to another updated guideline, first trimester fetal echo should be primarily based on situs determination and obtaining four-chamber view and cerebral trachea view. These are the machine settings for first trimester fetal echocardiography recently suggested by Ryder and Simon. For a better grayscale image, narrow window, magnification, and high-frequency probe is necessary. Color Doppler is also mandatory. Adequate box size, low PRF, high filter, and color gain adjustment is important. This is a systemic review of 63 studies and over 300,000 fetuses published by Papa Giorgio Group last year. The major finding is that more than half of fetuses affected by major heart defect were detected by first trimester fetal echo, and 68% in high-risk group. These are the anomalies you can expect to detect on first trimester. Both classification in detection rate is very similar and close to second trimester. You are able to detect the majority of hypoplastic left heart syndrome, tricuspid atresia, and AVSD. In cases of conotruncal anomalies or Epstein anomalies, the detection rate is around 40. Screening simple VSD is still challenging in first trimester. Why are these malformations classified like this? It depends on whether anomalies are easily detectable on four-chamber view. Today, I'm going to focus on the malformations we should always be able to pick out. The first case was referred at 12 weeks with fetal hydrops. The right side video clip starts with normal cerebral view. On four-chamber view, you can appreciate there is a large defect and bidirectional flow through common AV valve. Down syndrome was confirmed. In the case of fetal hydrops, the risk of congenital heart disease increases even though there is no chromosomal abnormalities. Therefore, first trimester fetal echo should be performed before karyotyping. This case was referred with increased nuchal translucency of 4.5 mm. There is still 6% chance of having congenital heart disease after karyotype being determined to be normal. If you look at the right side, there is only right ventricular filling during diastole, and you can see the atrial mitral valve and reversed flow from left atrium to right atrium, which is typical finding for HLHS. You can also appreciate the dilatation of pulmonary artery and reversed flow in aorta. This case emphasized the importance of situs determination in first trimester. She was a nurse without obstetrical risk, and she came to me at 13 weeks just for a routine screening. You can see the heart is on the left side and the stomach is on the right side. You can appreciate that there is single ventricle and single great vessel. She came back 1 week later. This is a typical appearance of a hypoplastic left heart. On three-vessel view, you can see large pulmonary artery and very small aorta. This fetus also had left-sided IVC, midline liver, no spleen, which are all associated with asplenia. If there is suspicion of situs ambiguous, you should look inside the heart. What about the right side heart? In this case, she was referred because of early omphalocele. You can see a very small right ventricle with diminished contractility compared to the left. There is a thick atrial tricuspid valve. If you look at the right side, you can see there is no flow crossing tricuspid valve. The three-vessel view demonstrates reversed pulmonary artery flow. In cases of any kind of extracardiac anomalies are found, first trimester fetal echo is mandatory. This fetus had hydrops at 12 weeks. Left side grayscale, you can see large VSD and overriding aorta with normal pulmonary artery. But when you turn on the color Doppler, you can appreciate the bidirectional pulmonary artery flow, but there is no dilatation, which is typical in second trimester absent pulmonary valve syndrome. It is very detectable if you turn on the color Doppler on pulmonary artery. The detection rate of conotruncal anomaly is 30 to 40%. Tetralogy is one of the malformations you can detect only sometimes in first trimester. It is easily prone to false positive or false negative. This patient was referred at 12 weeks with thick NT. As you can see, this clip is lousy because of maternal obesity and anterior placenta and fetal extremity. I should have tried transvaginal approach, but I didn't. I told her at least 4-chamber view looks normal and asked her to come back 4 weeks later. When she came back, I was shocked to find out something went wrong. Overriding aorta and retrograde ductal flow. I reviewed the previous video clip and there was already Y-shaped overriding and no pulmonary artery beside large aorta. This is a human error. The baby underwent successful surgery and is doing well. Because I missed early diagnosis, you should be more careful in high-risk group. This is another case of tetralogy at 12 weeks. She had no particular risk for congenital heart disease. You can see left side deviation of cardiac axis and blue-colored Y-shaped overriding aorta. I was not able to find pulmonary artery flow beside large aorta, which suggests pulmonary atresia, but it was due to my technical error because this fetus was pink TOF at 12 weeks. I should have tried to lower the PRF or to perform vaginal ultrasound. Actually, evaluating pulmonary artery flow is important for counseling prognosis, but it's still challenging for me, especially when pulmonary artery is too small. This is the most interesting case I want to show you. She had a previous baby with tetralogy. As you know, the recurrence risk is about 3%. Next pregnancy, she came back to me at 12 weeks. Unfortunately, there was VSD, Y-shaped overriding aorta, and small pulmonary artery, which means recurrence of tetralogy. She came back 1 week later for confirmation, and you can see a large left to right ventricular shunt through VSD, which is suggestive finding of DRV, and you can see a large overriding aorta mostly connected to right ventricle and large pulmonary artery also arising from right ventricle. At 20 weeks, the final diagnosis was isolated VSD DRV type. you should keep in mind there is always false positive in first trimester fetal echo. If you try first trimester fetal echocardiography, you can detect more than half of congenital heart disease, and it is higher in high-risk group. In cases of malformations with abnormal four-chamber view, majority of cases are detected. You should keep in mind there is always false positive and false negative, especially if you are a beginner and not using high-end equipment. Thank you for your attention.